Okay, we're recording. Go ahead.
So we have that project coming up week 7, and there's a group of us.
Yep.
That is so challenging. We all in different states and stuff like that. Really ain't
Just
never exchanged numbers or nothing
here's an in your student shell, you should have the emails of the students.
for
So,
everybody.
Sierra, listen,
So
I'm gonna
hang
email
on.
you
Here,
my
here's
number.
here's the easy way to do it. During the chat today, you can put numbers in the chat if you want. However, somebody just needs to take the lead and send out a group email and say, hey, which part do you want to do?
Okay.
There's 4 parts.
I'm gonna
Okay.
email you my number, Sierra. I'm gonna email it to you
Okay.
right now.
So you
I
guys
think
can
it's two
put
more people.
numbers in the chats. You can send out in the chat. You can send out a message to your teammates for put numbers in, right? You guys can respond to each other in the chat, right?
Yeah.
Yeah. Does that help?
Yeah.
I know everybody's on different campuses. I get it. But that we have to. 1 second, let me get people in so I don't mark anybody late here.
You can also do it through the inbox in Canvas.
Yep.
That's what me and my group did. We inboxed
Yep.
each other through Canvas.
Yep.
We already started it, so.
Okay.
Do you want a written paper or a PowerPoint?
No, this is just a written paper. PowerPoint is your vulnerable populations assignment due in week 10. This is just a written paper. But a couple of things. One is it has to be a paper. Don't everybody submit me their portions. Okay. Somebody needs to
Come
take the
together.
lead of putting it all together into one paper. And then you submit that. It's in the discussion post format so that you can respond to two peers, right? So just when you submit to the discussion post, just click on as an attachment. Or you can copy and paste the whole thing into the discussion post. Either way, either
So we're
way.
just we're copying and pasting as a discussion in paper form,
Yeah. Yeah.
not sending the paper.
You could. I mean, I'd love to have a paper as an attachment, that has
Okay.
a cover sheet that has your first names on there, and that'd be great.
Okay.
However you want to get it done. I know that I'm going to be getting 4 of the same copies of each of your assignments. I'm well aware of that. But everybody has to submit in order for it to give credit in the grade book. Does that make sense?
Yeah. So we all doing our separate parts. One person is taking the lead. We combined it in all to a paper with a face sheet that can be attached as an attachment. But it's easy to just copy and paste our paper into the discussion still to submit it to you. But no
That's
matter
fine.
what, we still submit it separate.
Whatever's easiest. I don't mind reading them in long form in the discussion thread, and I don't mind opening an attachment. Either way. Okay.
Sierra, I just emailed you.
Who just emailed? Somebody just emailed me. I don't know who this is. Oh, Ariana.
And now I'm trying. You're good.
You're in?
I've been on my phone. I just have
Oh,
to
there you are. Yeah, you're fine. Okay, just got it. Okay. All righty. So we're gonna get started, even though we're missing a few students. Lakeisha, we're missing. That's it. Just Lakeisha. Okay, so we got a lot to cover today. We're covering weeks 4 and 5. Okay, so we are covering pregnant adolescents, LGBT. Excuse me. 1 second. Sorry. This might be my AAA. Hang on. You guys, I'll be right back. Just need to sort this out. Be right back. You know, now could be the time that you guys could exchange numbers.
Keisha's having difficulties getting in.
I don't have anybody in the waiting room. Okay, sorry about that. Let's see, I've got Geraldine coming back in, Ariana coming back in, and Lakeisha is here. Okay, so everybody should be here. Sorry about that.
I'm sorry, I was having difficulty.
What was your difficulty? You just couldn't get on, or
Yes, I
Lakeisha?
was saying the wrong code in.
Oh, okay. Okay, so let's get going. So week 5, you made it to week 5. Happy Monday. Everybody organized with all their classes? Everybody have a plan?
Yes, ma'am.
Okay. All right. Let's see. Allie's not here. Okay, so a couple things. You already started talking about your group project. First of all, I need everybody on camera. Crystal, I can only see your wall behind you. Tawana, there you are. Okay. So you know about your group project. I sent out the all your groups. If you want to read about the group project, it's in week 7, right? I kind of copy and pasted it into your announcement, but week 7. Please look at the rubric because that's how I grade. Okay. What else did I send you an announcement about? Oh, exam 1 grades are obviously posted. I've heard from some students to review their exam, but if you score below a 78, really it will benefit you to review the exam, or at least the concepts missed. Okay, so I'm happy to do that with anybody. I really want to do it with students who score below a 78, and then anybody who scored above 78, I'm happy to go over what you missed. Okay, I have students that score in the 90s or high 80s that still want to review what they missed. Okay, so that invitation is open to anybody. Okay, this is the week we start. Oh, we started last week. We have at-risk meetings with campuses. Does everybody know what those are? So every other week, half the campuses started last week, the other half are this week. These are at-risk meetings in which we meet with your campus deans and support staff. And if anybody's below a 78, or if anybody is a repeat student or a re-entry student, if anybody has attendance issues or missing homework issues, I have to complete an at-risk report. That goes to your deans. Okay. And so when the meeting comes up, we talk about a plan for success or how we can both coordinate communication to get you back on track or to attend class and not be late. So if you hear from your deans about why haven't you turned in these 2 assignments, or you've been late for class a couple of weeks, or have you reached out to your instructor to set up some tutoring for your exam grade? That information is coming off that at-risk report. Okay, so it's not tattletaling. That's not what it is. This is a requirement for the professors to communicate to the deans via these written reports what students might be struggling in different areas. Okay, does anybody have any questions about that? Okay, what else do we need to go over? Anybody have any questions about anything? I'm hoping to get the exam 2 study guide out to you this week, or blueprint review. Okay, today we're going to cover weeks 4 and 5, and then next week we'll cover 6, and then that's the content for exam 2. All right, so next week will be the reviews again. Okay, so you have the master schedule of the reviews, and it's pretty standard, pretty easy to see that, just from this particular exam that you just took, the students that attended live review sessions did well. For the most part, did well. So that's why I gave you the schedule at the beginning of the term to prioritize, I don't know, work schedule, childcare schedule, to see if you can try and attend one of these live reviews, and they're all next week. Okay, and I sent out an updated version a few weeks ago because I changed my Wednesdays from 3 p.m. Eastern to 9 a.m. Eastern to accommodate students that had class that afternoon, a lot of students. All right, so please go back and look at the schedule. Okay?
What we've been trying to do too is communicate back and forth also with peds, because a lot of the reviews that's happening, it used to be easier to sit for every review. I'm sorry, my 1-year-old is singing.
That's okay.
But we normally could sit well, but now it's like with us having that class 1 to 8 on Wednesday, and then clinical 7 to 3 or 2, it's kind of hard because now it seems like everybody's reviews for community and peds are overlapping, like they're the same.
What would work?
I needed tutoring for the math on peds. Luckily, we didn't get that math, but I chose to sit for the review for community. And it's like with classes being every other day, I'm still trying to level it out like when. So that's why I like that you made our tutoring session for Wednesday. But I'm kind of displaced with trying to find the right time to read the right information
Mhm.
with everything so spaced out.
Sierra, we'll talk about that Wednesday. Sound good? All right.
That's perfect.
Okay. All right. I'm going to start with our content. So we're going to go over briefly go over each of the 8 concepts. I told you about week 4, and then this week, hospice and palliative care, death and dying, faith and spirituality, and ethics. So these are 8 really important concepts to community nursing. And then after we go through the content, we'll take the quiz. I've already opened up the quiz, but don't take it yet. Okay, please. All right, let's go through some content. Okay. I pretty much give you what my lectures are going to be about. I didn't do this in the RN program, but I do this for the PNs. Okay, so can everybody see that? Yes, no? Okay.
Yeah.
So this is pretty much what we're covering. All the information in your weekly notes is really my notes for lecture. So it's you listen and kind of follow along. So if you want to pull up your notes, that'd be fantastic. So as I said, we're covering some of the special vulnerable populations: pregnant adolescents, LGBTQ, mental illness, alcohol, tobacco, and other drug problems. And if you look at the readings, okay, there's a couple of chapters that you're responsible for, 47 and 48. And in your module, there are, I think there were chapter 47 and 48. There were no active PowerPoints for that. I'm trying to get that fixed. You only had a couple of pages in growth and development and chapter 41, 11 and 41. And then introduction to maternity and peds, you only had a couple of pages in each of 19 and 20. What I want you to point you to, that it's fine to go through these notes, right? But look at the Canvas course. You have 3 teaching sheets in your Canvas course in week 4. One is for pregnant adolescents, one is for LGBTQ, and one is for mental illness. Has everybody seen those? And everybody knows where I'm talking about, where to find them, right? Right in your module. Okay. All right. So special vulnerable populations, right? We know that vulnerable populations, they often have poor health outcomes, right? With regards to morbidity and mortality, right? We know that vulnerable populations have a higher incidence of chronic illness. Okay. In particular, pregnant adolescents. Has anybody ever worked with teen pregnancy clients? No, nobody has? What are their needs? What could go wrong? Why are they considered a special vulnerable population?
Because they can give birth early.
Yep. Preterm
Or they-
birth.
They don't
Another
eat
thing-
healthy.
They what?
They have lack of knowledge.
Their eating habit is not good.
Another thing is, a
Anxiety.
lot of when they get pregnant, they don't get the right help. They be so scared to tell their parents, they hide it. So
Exactly.
they don't get the proper
Ma'am.
care.
Exactly. Great.
Anxiety.
Anxiety. Right. So we know that there's a direct correlation between poverty and poor health outcomes, right? So let's talk about the poor teens for a minute. Poor teens, or teens who are pregnant who live in poverty, are 3 times more likely to drop out of school. Okay, and that's important because if you get a question on your next exam that says, what is the most important thing to make sure we do for teen pregnancies? If the answer is keep them in school, that's the correct answer. Sure, it's important for good nutrition, follow up on your visits, have a support system, but the most important intervention strategy is to keep them in school, right? Because when they are kept in school, and they are you're assisting them in improving their education, there's a couple of things that happen that are positive. They have a chance for a better future, which will improve their health of them and the baby over the long term. Okay? They make better decisions. They process things better with increased education. So we got to keep these guys in school. In the district I worked in, huge district here in Denver, we actually had a special school, Warren Tech, that a section of Warren Tech was for pregnant teens.
My mom worked at a school like that
Yeah.
here. Yeah, she was used to work there for a long time. It was for pregnant, some was for pregnant teens and
Yeah.
like other kids who,
Mhm.
got kicked out of other schools.
Right. Well, and has a midwife has a psychologist, a midwife, OB nurse. I mean, very geared towards making sure these teens get the support they need. Okay. Pregnant teens have a higher rate of STDs, higher rate of addiction to drugs and alcohol, poor nutritional status, and compromised birth outcomes, whether it's preterm birth, low birth weight, issues at birth, right? What if you have a pregnant homeless teen? I mean, they are at the highest risk possible. Okay. We know that racial and ethnic minority groups have a higher rate of teen pregnancy, and that correlates to having a higher rate of poverty, lack of education, higher rates of abuse, violence, sexual victimization. So some factors that contribute to teen pregnancy: low income, lack of education, lack of social support networks, and maybe living environment exposures, such as abuse, trauma, neglect, sexual victimization. Okay, so as a nurse, let's say you're doing a postpartum visit with a pregnant teen who's just had the baby. What kinds of things are vital to assess right off the bat?
Their mental status,
Mhm.
Housing.
What about their bonding with the baby?
nutrition, yeah.
Bonding with the baby is the most important, right?
Absolutely.
Do they react to the baby's needs? Do they have eye contact? Do they swaddle the baby? Do they have some indication of growth and development? Okay. Let's see. Here's some primary, secondary, and tertiary examples for teen pregnancy, right? So primary, remember prevention. Maybe we develop appropriate sex education and we start that early. The sooner the conversation happens, the risk lowers a bit for unintended pregnancies, right? Secondary, how do we identify high-risk adolescents? Screening them. Are adolescents who have a history of substance abuse, a history of sexual, physical, emotional abuse, they are at higher risk for teen pregnancy, right? And then obviously tertiary, they're pregnant, right? They're pregnant. So then we have to identify what the immediate concerns are. Do they have an inclination to talk about abortion versus keeping the baby? Nutrition, school. Very, very vulnerable population. Okay, and here's the bonding. Teen mothers may struggle to bond with their baby. Do they feed appropriately, change diapers appropriately, make eye contact, those kinds of things. So bonding can be a real red flag. Okay. Okay, let's move on to LGBT. So we as nurses, we have an obligation to provide culturally competent care to LGBT families. What do I mean when I say culturally competent care? We're going to cover that in week 5, but what's culturally competent care?
Would you say the, what, like the proper care for, like, for instance, Jehovah Witnesses don't accept blood. Like actually getting that culture and following their rules of healthcare. Some don't like the women being uncovered or seen. Jewish need a candle burning, during the death process. So like some along that nature. It's like following.
Yes. Being culturally sensitive to whatever lifestyle they have, right? Some nurses may feel some discomfort and discussing sexual orientation with their clients, right? So we have to check our own values. We have to check our own beliefs. It's important for us to overcome barriers if we have them with regards to caring for LGBT clients, right? We need to provide safe environments for them to be able to discuss their sexual orientation. They are considered, the LGBT population is considered a special vulnerable population. Once we understand our own feelings, then we are able to navigate through what the client's needs are. Okay, so the purpose of cultural competence is checking our own feelings and checking our own beliefs. Right? How do we take, let's say we're doing an assessment. How do we do an open, non-judgmental history, sex and social history, without
Different wordings
Mhm.
that you can say, like, and like, so normally people ask in some questions like, do you have a boyfriend, girlfriend? But now you have to say, well, do you have a partner?
Yeah,
Or
perfect.
stuff like that.
That's exactly
Um,
right.
What is your
Yeah.
preference? Like that, and not, do you like boys? Do you like
Yeah.
girls?
Right.
Okay.
So
And
you have to,
address them. I'm sorry. And you also, if they're trans, you address them as appropriate. Like woman, if they're trans woman, woman, if they're trans male, male.
A lot of them like to be called they.
Pardon me?
A lot of them like to be called they.
Okay.
Yep. They, what is it? They, them,
Yep.
they and them, they and them.
Yep.
Yeah.
So it's important. That's my point. It is important to know how they would like to be communicated to, how they like to be identified as. Okay. And your reading in your module on the LGBTQ page is really informative. So please go back and read that. You're actually responsible for reading that. Okay, so with regards to LGBT, CDC has recommendations on screening for prevention of sexually transmitted infections. And that's this paragraph right here. So I need for you to be aware of what is recommended for screening. So there's an annual screening for HIV, genital herpes, syphilis, gonorrhea, and chlamydia. Okay, they recommend screening interval is 3 to 6 months for those that are particularly at high risk. Okay, what's considered high risk? Individuals with multiple sex partners or who use illicit drugs in conjunction with sex. So those are the few things that you need to know about LGBT is how do we establish a trusting and therapeutic relationship? How do we do an assessment that's non-judgmental using questions that don't assume anything? And what kinds of screenings are recommended by the CDC? All righty. Mental illness, big problem. Big problem in our country. I saw that, I can speak from my school nurse experience in the pandemic. Yes, there were mental illness issues, but the mental illness issues increased exponentially during and after the pandemic. Why do you think that is? What happened?
Alone, being alone.
Isolation,
Losing their jobs.
Yep.
parents losing their jobs, having to stay home with kids.
A lot of death.
And just,
Lot
I feel
of-
like unpredictability of it all. Like there was no set in stone. Everyone was just like,
Yep. Lots of mental illness. And mental illness has skyrocketed since the pandemic. Anxiety is a common emotion that's considered normal, right? However, if it's so debilitating that it impairs our ability to function, that's considered a bigger problem. Okay, abnormal or debilitating anxiety is intense and feels life-threatening. So there's anxiety that is manageable and there is anxiety that is not. Right? We're all at risk for some sort of anxiety due to our whatever physical, psychosocial, developmental, cultural, spiritual implications that happen in our daily lives. Okay? Patients with anxiety disorders may have other mental health issues as well. Major depressive disorder, substance abuse. So let's talk about some of the mental illnesses. One, GAD, what is that? General anxiety disorder. You're going to get asked about this. Okay, so we have to understand what that is. General anxiety disorder a person experiences persistent, unrealistic, or excessive worry about two or more life circumstances for 6 months or more. Okay? You can read through the rest of it, but that's in general what general anxiety is. What about phobia? A person with phobia experiences irrational fear of a specific activity, a situation, or an object. So the fear can lead that in there. The fear can lead to avoidance or extreme anxiety that interferes with normal responsibilities. What are some common phobias? I'll tell you what, I have a phobia of snakes. I can have spiders crawling all over me, but I see a snake and it's this big, even a worm.
Yep, agreed.
So
Heights.
go ahead. I'm also
Fear of
claustrophobic.
heights. Oh yeah, my dad had that.
I'm claustrophobic too. It's real. It's real. Next one is OCD. So here what I'm doing, guys, is I have 4 paragraphs. Anxiety number 1, general anxiety disorder number 2, phobias, OCD, and PTSD. Those are the mental illnesses I want you to know about. Okay, you're going to get asked about all of these or be presented a scenario and asked which kind of mental illness is this? Okay, so OCD experiences an obsession, recurrent or intrusive thoughts that they cannot stop thinking about. What's PTSD? Previous event that involved threatened death or serious injury to yourself or others. Could be kids witnessing violence, witnessing a crime. The remembrance of these events produce intense feelings of anxiety, nightmares. Okay? I want you to remember this statement here. As in all vulnerability, kids are at the highest risk for mental disorders, secondary to adverse circumstances. Okay, kids are at the highest risk. So if you're asked a question, which group is highest risk? A kid, an adult, an elderly person? It's always the kid. Okay, everybody's vulnerable, but kids are most vulnerable. What about if you're a nurse caring for a client who's taking lithium as a mood stabilizer? Lithium's used for bipolar. Couple of teaching points for clients taking lithium: encouraging normal salt intake and reporting any kind of diarrhea, tremors, or lack of coordination. So lithium is the one drug I want you to know about. There's lots of drugs that we use to care for mental illnesses, but I do want you to particularly know about lithium. The fourth vulnerable population: alcohol, tobacco, and other drug problems. Substance abuse, like mental illness, is a huge problem. Would you agree? Huge problem. So we know that it contributes to teen pregnancy, HIV, STDs, domestic violence, child abuse, crashes, fights, crime, homicide, suicide. Contributes to everything. We know that tobacco contributes to cancer, heart disease, lung disease, emphysema, bronchitis. Tobacco also contributes to premature birth, low birth weight, stillbirth, SIDS. What are some contributing factors to substance abuse? So let's take alcoholism, for example. Some people are predisposed genetically to alcoholism or drug addiction. It's a chemical makeup that unfortunately they have inherited, and it's important to know. It's important to do that as part of, know that as part of the history taking. Same with mood disorders or other mental illnesses. They may be genetically predisposed, but if not, they still have to be dealt with. And a lot of people try and self-medicate with alcohol, drugs, whatever. Okay, which just perpetuates an ongoing, really bad situation. Our social environment, our culture environment, our family environment all contribute. Okay, life is moving fast now, right? Lots of stuff going on. It's hard not to get distracted. Okay, but as a nurse, it doesn't matter wherever you're going to work, whatever setting you're going to work. You are going to be working with people that have mental health issues. You're going to be working with people that have substance abuse issues. Okay, so it's part of our foundation now. So again, wherever you work, you still have to be prepared to care for those clients. Okay. Here's some terms and definitions that you can go through. Substance abuse versus drug dependence versus drug addiction. Okay. Here's some examples of some psychoactive drugs, whether they're depressants or stimulants or energy drinks. Okay, so have a look at that. Here's some substance specifics. Nicotine, vaping. So what if you are working with a family that is a smoking household? This is a vaping question. You're working with a family that is a smoking or vaping household, and the kids have asthma. You're the school nurse, okay? You know it's a smoking household, the kids have asthma. And so you make a home visit and you do teaching about the dangers of secondhand smoke, the dangers of smoking in the house, smoking in the car, because the goal is to have a smoke-free house. When you're finished your teaching and you want to reassess how much the parent has learned or what they got out of it, what if they say, well, I now smoke outside versus inside? Is that better?
Yeah.
It's better. Okay, it's better. Well, I cut down from 2 packs of cigarettes to 1 pack of cigarettes. Is
Yeah,
that
that's
really
kind
better?
of, yeah, a little bit. Not
A
it,
little
but
bit. Okay. What if they say, you know what, don't worry about it. We're all set. We stop smoking, we start vaping. Is that okay?
No,
No.
still bad.
No. The answer is no. What's wrong with vaping?
It's chemicals.
Pretty much the same thing. Yeah.
Chemicals. It's still as dangerous as smoking. And the one thing that vaping is very high risk for is the chemicals are poisonous if kids get into it. All right. So if a parent thinks that in your teaching, in your post-teaching assessment, if a parent thinks that vaping is okay now, that has to be corrected immediately. Everybody get that? Secondhand smoke is toxic. Vaping introduces the lungs to chemicals and toxins and associated with lung damage. Increase for respiratory illness. Okay, so there's a little blurb I want to specifically mention about vaping. And alcohol abuse caused billions and billions of dollars a year, lost productivity, property damage, medical expenses, alcohol-related illnesses, right? Whether they're from accidents or family disruptions, abuse, neglect. Okay. What I'd like to point out in the alcohol information is how this last part, how alcohol is metabolized. What can the bodies take? What can we metabolize? Well, we can metabolize about 4 ounces of wine per hour. I guess so. Let me take a step back. How do we assess a blood alcohol concentration? It's not just from how much you drink over how much time. There's several other things. What else contributes to the blood alcohol concentration? The rate of drinking, the rate of absorption, have you had any food, rate of metabolism, person's
Age of
weight,
the person.
huh?
Let's say the age of the person as
Yeah,
well.
age of the person, weight, sex, all those contribute to it. So there's not one indicator that we assess blood alcohol concentration with. There's several. Okay. Then there's a little bit of information on cocaine, on amphetamines, methamphetamines. Just read through this section. Okay. You're not going to get asked a whole bunch of questions about this section, about all what I really need you to know is the different kinds of specific substances. There's nicotine, there's vaping, there's alcohol, there's cocaine, there's amphetamines, and there's methamphetamines. Okay. This is excellent here. So if you were working in the community and you were going to set up a substance abuse prevention program, here's a bunch of primary interventions that you could do. You could say again for your reading. Okay. Okay. Any questions about week 4? Please read through the notes and go back and read through your modules. Okay. The readings in your modules, the mental illness, LGBTQ, and I think mental illness. Okay. All right, let's go to 5. Whoops, I didn't share. Sorry. Let's go to this week's information. What are we covering here? Today we're covering hospice and palliative care, along with death and dying. We kind of group that together. Faith and spirituality and ethics. Anybody ever worked with a hospice nurse or worked in palliative care or hospice nursing? Those people are my angels. They truly do God's work. Okay? With a hospice client, with regards to death and dying, we're focusing on the needs of the client. There's only a couple of things we're really focused on: keeping the client comfortable, maintaining dignity and self-esteem. Right? We do want them to be pain-free, or at least be able to control the pain, but we don't want them so sedated that they have absolutely no idea what's going on either. Okay, we want them to still be able to try and interact with family members and participate in their care decisions, if we can. We know that the family, the extended family, is also grieving along with the client. But remember, the client is the most important. All right. We know that we have to follow the doctor's orders, but making the client comfortable and maintaining dignity are the priorities. What's hospice and palliative care about? To alleviate suffering as much as possible. We know that we can't cure, right? We cannot cure what they have, but we can try and improve the quality of the remaining life. Right? Helping them accept death as normal and expected. They may have said, I don't want any more aggressive treatments. We have to respect that. So our goal becomes quality versus quantity. Okay. They may also request spiritual support. Hospice nurses have those resources. And one thing to remember, that dehydration in the terminally ill patient has actually been shown to decrease the pain and to be more comfortable than a tube feeding or an IV. So dehydration isn't all that bad. Usually families are cared for in the hospice setting, either in their home, long-term care facility, clinic, bigger facilities. And we know that hospice is truly the end stage of life. Okay? According to the World Health Organization, the WHO, the goal of palliative care is to improve the quality of life of patients and their families as we deal with the life-threatening illness. Okay? Generally, the patient has a prognosis of no more than 6 months. All right? Once the team realizes that there is no cure, then the hospice discussion is initiated. Lots of different kinds of support: nursing care, social support, psych support, spiritual support. What does physical support look like? Alleviating pain, trying to reduce air hunger, improving sleep. Social support. What are some examples of social support? Facilitate relationships that may be strained or neglected, that the client may want to mend. Updating a will, saying goodbye. Spiritual support. What are some examples of spiritual support? Maybe finding peace with God or whatever your higher power is through a chaplain or a spiritual advisor. Lots of things to consider. The one thing you need to be aware of is the stages of grief. Stages of grief go along with the death and dying process. Okay? So denial. If you're in denial, the nurse should stay with the family. Okay? Maybe showing acceptance of feelings for them is acceptable for the acceptance or reorganization phase. Providing information needed for decision making. That could be the bargaining stage. And then suggestions for referral to mental health may be appropriate for depression. Okay, so this first paragraph here talks about the stages of grief. Why do we not want to be the ones that are making decisions for the client or the family? It's called autonomy. It's one of the ethical principles. It's called autonomy. Making decisions for the client removes the autonomy. Autonomy is an ethical principle in which we want to encourage the client to be as autonomous for as long as possible, participating in their healthcare decisions. Okay? And if we decide that we're going to be the ones making decisions, this is ineffective. It can further impair the communication and the relationship you have with the hospice patient. Right? You want to have open, honest, trusting conversations. Okay? Therapeutic communication is kind of similar when we were just talking about the LGBTQ population. Being sensitive, how you ask the questions, not to imply anything, or for example, let's say the patient says something like, God is punishing me. Well, we certainly wouldn't want to respond with, well, everybody dies, you're not being punished. Or I'm sure God will forgive you. And that's not an appropriate response.
What is it? It's like, okay, to just say, well, why do you think that
Yeah,
God is punishing you?
an appropriate response would be, this is a bit out of your realm as the hospice nurse, so maybe we offer to get a spiritual advisor that can discuss this in-depth part of the end-of-life clients, right? With regards to pain control, we're not worried about addiction or dependence at this point, right? So if the client doesn't seem to be adequately pain managed, it's okay to call the doctor and give him that assessment. And if more pain meds need to be prescribed, that's fine. There's other ways, guided imagery, relaxation techniques, breathing, massages, music, meditation. But the point is, there's no need to be concerned about addiction or dependency, since one of the goals of end-of-life care is adequate pain management. Okay? Hospice nursing, palliative nursing, the process of death and dying can be extremely challenging and mentally draining for nurses. And again, we have to be able to check our own values and beliefs, right? Before we begin this kind of work. All right? Faith and spirituality, and I throw culture in here too. So I'm real big on culturally competent care. Culturally competent care requires that we, as nurses, have an understanding of our own culture and any biases or stereotypes that we might have. We can't make assumptions. Our culture isn't any more important than anybody else's. We don't place it above others. And at all costs, when we're planning client care, not only should we be knowledgeable about the culture, but we should try and incorporate whatever the values, beliefs, practices are of that culture, if we can, into their plan of care. Maybe it's dietary modifications. Maybe it's certain visitors, whatever their values and beliefs are. For example, like the Native American population, if they're in the hospital, they like to have a spiritual advisor with them, right? And the Hispanic population, they like their family to be with them at all times in the hospital. Okay? So we just need to we're going to be exposed. I mean, I've been a nurse for 40 years as of May. I have been exposed to so many cultures over my nursing career. Do I remember every culture? No. Do I remember a lot of, if I was I covered many, many schools. I would have schools that live in a Hispanic community or a Somali community or a Hungarian community, whatever. I was always asking questions of the students and the parents. Tell me about your culture. How can we incorporate that into your kids being successful at school? If you have special dietary needs, I want to make sure I communicate that to the cafeteria. We have to do our best to be culturally knowledgeable, sensible, educated. It's not to say, do we know everything? Absolutely not. I'm still developing cultural competence, but it's okay to ask. Okay. Other cultures won't see you as ignorant or uneducated. They appreciate it. They love telling you about their cultures. Okay. Some cultures are future oriented, past oriented, presently oriented. Okay, so I want you to read this paragraph, and it gives you an example of a past, future, present. Let's say you're past oriented. You probably don't care about what's happening in the future, right? Let's say you're present oriented. You're probably not thinking about how your behavior or decision affects the future. Make sense? So cultural competence requires that we approach each client as if they are a unique individual. And like I said, we gather as much information as we can on their values and beliefs. Maybe if you live in that community, you attend a gathering of that culture to learn more about that culture. Okay? So the other thing that's important is we don't treat every culture the way we expect to be treated. Because what if the cultures are vastly different? Right? And the other thing we don't do is we don't only educate ourselves on certain minority cultures. We want to educate ourselves on every culture. No culture is less important than any other. Okay? Finally, when cultural competence, here, I'm going to highlight this. This is the biggie. This is what we're working towards in our nursing careers. Cultural competence is finally attained when we as nurses make a conscious attempt to learn about people of diverse cultures and look at the world through their perspective. Does that make sense? Does anybody work with anybody in their workplaces or in their personal lives that is culturally insensitive? There's still a lot of people out there that are culturally insensitive. We have to move towards cultural competence in our careers. One of the roles in culture and faith community is the faith community nurse. Believe it or not, there's a school nurse, there's a vaccination nurse, there's a public health nurse, there's an occupational health nurse. There's also a nurse called a faith community nurse. He or she may be in a church, a congregation, a mosque, a temple. Okay, we call that person the faith community nurse. Okay, they are tied into that particular congregation. Okay, and they provide nursing care just like we would, but what's added is the spiritual factor. Okay, so it incorporates all of what we would do and then the spirituality piece, okay, of whatever your belief is. Okay, they may be volunteers, they may be hired by the church, their role is primarily health education, so they may be the ones going out to visit the new parents or the teen mom, or they may be the ones holding grief support groups for hospice patients or family members that have died. They may be the ones providing substance abuse support groups. They may be doing health fairs. A lot of their focus is on health education, health promotion. bringing in community resources, much more of a holistic approach, incorporating body, mind, and spirit. Okay? Does anybody, I have 2 friends that are faith community nurses. It's awesome to hear what they do. And whatever the congregation wants them to do. Do they want them to do the home visits? Do they want them to do support groups? Do they want them to do health education, or all 3? They're part of the group. Okay? And you can read through the rest of that. Ethics. Why is ethics so important in nursing? It guides us, right? We have ethical issues every day in our lives, whether it's personal, family, work, school. We're always faced with ethical decisions. Okay, one of the important things to know first off is that the first step in ethical decision making is identifying the issue to be faced. Think of your ADPI, think of assessment. We have to know what we're addressing. Right? The other thing is, what if you're asked to participate on an ethics committee in your organization? What does that ethics committee focus on? Okay. They focus on processing ethical dilemmas, providing education, and maybe providing policy recommendations. They do not provide care, nor do they approve any kind of mental health emergency commitment. That's just not what they do. So when we think of ethics, we think about moral distress. Okay? What that means is when I'll speak for myself, when I am unable to act accordingly with what I'm supposed to be doing. What would you all be doing in a certain situation, and then I cannot do what you're doing? That's called moral distress. So moral distress in the nursing profession may include end-of-life decisions. Think about the ethics of these examples. End-of-life decisions. Maybe your patient load is too high. Maybe you struggled or still struggling with COVID-19 visitor policies. Okay? Anything that's morally distressful to you. Okay? There's a couple of there's a couple of ethical principles. Sorry. Beneficence. What's beneficence? Do good. Okay? Beneficence is do good. Do the most good possible within the circumstances, which means you are consciously trying to practice within your scope of practice and practicing within the standards of care. You're trying to do good. Okay, so ensuring pain control is an example of beneficence. You're trying to do good, make the patient feel better. Another principle is distributive justice. Everybody has access to the same resources. That's an ethical principle. Okay, so an example of that would be maybe we as the nurse go speak with the insurance company about maybe a drug that is not covered under their insurance company, but you think would have a great benefit and cost effectiveness to the client. Right? Giving you a client who's technically not covered for that drug in the insurance company, but then working with them to see if they can have equal access. Does that make sense? Non-malfeasance is another one. The third one, do no harm. Do no harm. So in our conscious effort to practice in our nursing profession, we should be practicing non-malfeasance, which is do no harm. Then the last one we've already talked about is the principle of autonomy, which is respecting the client's rights to be participatory in their health care decisions, if possible. Okay, we've all heard about standards of care, right? Standards of care are what we follow. What is our common or acceptable level of care that we're expected to be providing? So they essentially define our practice. So how does the American Nurses Association play into this? This is important. What do? They have formulated general standards, not specific, because we're all supposed to be guided under the guidelines of the American Nurses Association. So what do? They have general standards for nursing practice. General, not specific. General. They are broad and general, and they apply to everybody across the nation. Okay. Next is advocacy. That's what we do our entire profession, do we not? We're always advocating. Nurses are the go-to for everything, are we not? Family questions, friends questions, school questions, client questions. We're advocates for lots of people, right? And that's what advocacy is. Using our information and our resources to benefit the client, acting in the client's best interest. Certainly maintaining confidentiality. Okay? And you can read through the rest of that paragraph. What happens if you can't care for a patient? Let's say, and the examples in here, let's say you work in a prison and your sister was murdered a couple of years ago, and you're taking care of people that have committed that act. Does that give you moral distress, or is that an ethical dilemma for you?
Yeah,
If
I
it
think
does, yeah.
yeah.
If it
Notify
does, my point is you can't abandon the patient. Even though you have moral distress, ethical dilemmas, you must find a suitable alternative plan to care for that patient. Okay, here's an example. Working in home health, and you're working with a client that's making unwanted sexual advances towards you. What do?
I mean, professionally, you should redirect them into the proper way to handle and work with you. But I still feel like, even though we encountered and maybe the patient might have turned around and did better, I still feel like it should be reported to somebody else. So just in case the next day you come to work,
Absolutely.
they turned around and said you did something.
But
because they scared you told.
Right. And let's say Sierra, you just morally can't do this anymore. Too uncomfortable. Maybe your child was sexually assaulted, or your mother was sexually assaulted, or your brother, whatever. You just morally can't handle it. My point is, that's perfectly okay. We can't abandon the patient. We have to come up with another plan. Okay? A lot of ethics going on in nursing. We are faced with ethical decisions every single day. Like I said at the beginning, in our personal lives, in our school lives, in our work lives, we're facing ethics. You don't even know it. We're just always facing what's right and what's wrong. That's what it's about. What's right and what's wrong. Right? So, anyway, there's 8 concepts covered pretty quickly. So please, I skimmed through the notes. So you are responsible for all of the notes, but the notes are, like I said, the notes are awesome. They're awesome. And when I get you the blueprint review guide for exam 2, I copy and paste a lot of what's on your notes and just tone it down to what you're expected to know for the exam. Okay? How we doing? Did you learn a lot today? Okay. All right. So let's everybody, it is 4:09. Let's assume it's 4:10. Let's take 15 minutes until 4:25 to complete quiz 3. Please try and get it done within 15 minutes. Okay, and then we'll spend the last few minutes reviewing the quiz. Okay, you got to stay on camera to take this quiz because it's a key graded assessment. All right, so go find quiz 3 and take it. I'll see you in 15 minutes. Hey, you've got about 3 more minutes, so if you haven't finished, try and finish up. And everybody needs to submit before we can review it, so make sure you submit. All right, everybody done? Sierra, what do
I'm
you-
on 10. I'm on 10. I'm on 10.
Okay, all right. I have a lot of people who haven't submitted, so please make sure you hit submit. Can't review it until you've submitted it. Okay, Crystal, you need to submit, please. If you could hit submit. What?
Just reading my message.
Oh, okay. All right, let's review these.
Did I
Oops,
do it?
I got it. Okay, 1 second. Can't do that. Second. Okay. Share my screen. All right, can you guys see my screen? The
Yes,
nurse
ma'am.
school nurses engaging in primary prevention. Which intervention is appropriate? If you're talking, you're on mute.
Contraception.
Say that again. What's a
sorry.
primary
Yeah, B.
prevention here?
B.
B.
I'm just talking and it's on mute.
Yeah, that's okay. Discuss where and how to obtain ongoing contraception, right? Preventative. Okay. What's C? Primary
it-
sec.
The script
That'd be
is,
treachery, right?
That person have it
pretty-
already.
Yep. Yep. What's D?
That's actually that's the preventative before it can even happen.
Yeah.
Well, D is actually tertiary because they're
Oh.
pregnant,
Right.
Oh,
Okay,
wait, yeah. The
got it.
prenatal diet.
right? What about A? What's A?
Be secondary.
Secondary.
Yeah.
Yep. When which counseling is appropriate to provide to a pregnant adolescent?
A.
Yeah. A.
Everybody get that right, I hope.
Yeah.
Okay. Because the rest are incorrect.
Yeah.
Which
I thought
intervention?
I changed my answer.
Well, don't change answers, guys. Don't.
Well,
And
let's
here's another tip for exams. If you're an overthinker, if the information you're thinking about is not in the question, it doesn't exist.
Okay. So I can't wait till we get to my question because I'm gonna show you. So I just changed my answer at the last minute. As soon as you said my name, like I gotta do it. Because in this one, and they both to me was open-ended. I'd rather show you when we get to it.
Okay.
But it,
all
it
right.
seemed like it could have been two, but okay.
Right. So when before we even get to that, if your question seems like there could be more than one right answer, and it's not a select all that apply, you need to go back and read the question and see if there was an important word or cue that you missed, like best, first, priority,
Yeah.
most important. So we'll address that when we get there. What
Okay.
intervention should be prioritized, okay, for a child who has witnessed a violent crime?
It's gonna be
Obtain
C.
referral for mental health and counseling services.
Absolutely. Obtain a referral. So it's asking prioritization. Okay. All the other three answers maybe could be correct in some way, right? But it's asking what's the priority. First, we need a referral, and then the referral can help strategize the other three answers.
Yeah.
Okay. There's a great example of more than one answer looks correct. Go back and read the question. It was asking for a priority. Which nursing intervention reflects secondary prevention for mental health?
A.
Pardon me?
A. The
Right,
first.
screening. Right? B is primary.
Let her come.
Right?
It's okay.
C is tertiary because they obviously have a diagnosis of depression. And D is tertiary because they already have PTSD. We all get that?
Yeah.
Which
Yes.
nursing assessment is the most important in clients abusing oxycodone?
C. It's gonna be apnea.
I know I did
Apnea.
itching. I chose itching, but then I thought to do apnea, and that's the one I got wrong. I was like, come on. I thought of
Apnea. It's asking you which is the most important. They're all important, but apnea indicates a
Sleep.
yeah,
That's some ABCs.
right,
Cause they could be on that drug and then some of them
Right.
they just fall asleep
Right.
at the wheel.
Mhm.
Okay, number 6, which reflects tertiary prevention and substance abuse?
C A B C yes C.
C, right? Because they already have a drug
They
addiction.
already have addiction.
Yep. 7, which nursing intervention reflects non-malfeasance?
A.
Yeah, it's gonna be A.
I had to read that one twice.
Do
Because
no
I was
harm.
like, wait, it could be 2, but then I had to read feeding tube and
Yeah.
amidst who can swallow normally. And I was like, that ain't right.
Right. So A is the only correct answer.
Yeah, it is.
Do no harm. You're obligated to go find a new setup if you've contaminated the first one. Do no harm. The hospice nurse notes that the client's pain is poorly controlled despite the fentanyl patch as needed and is needed sublingual morphine. Which intervention is appropriate?
You wanna call a healthcare provider?
Right. Remember we talked about, we're not
Yeah.
concerned about addiction here. right? We need to let them know that what our current plan is not working. Okay, number 9, the client tells the hospice nurse, I do not understand why God is punishing me.
So this is the
See?
question right here.
Okay,
Also, at the last minute, I changed my answer from the last one from D to B because I thought it was like open-ended. So because he said that, I thought it was like, what makes you think you are being punished to ask them to get them to talk about it?
right? And so my answer to you is, what if that question creates real distress when you're asking them to talk about it?
Yeah, that's a good way to look at it.
You know what I mean? We're
Mhm.
just trying to, and are we in a position to have this discussion with the client? Would it be better for a spiritual advisor or
Yeah, so we can't tell that man, that person,
Yeah. It's just them opening. I mean, that's a good one. I like how you just broke that down because it helped me think a little
Yeah.
bit deeper. But at the I was torn between the two, and at the
Yeah.
last minute, I did change it. But
let me pray with you for forgiveness. Do they need forgiveness? Who knows?
yeah,
that ain't
Dying is just a normal part of life, not punishment. No, we don't want to say that. Okay. Number 10, client with metastatic cancer has made the decision to stop all therapies. Which statement by the nurse reflects a respect for the client's autonomy?
A.
A. Is the other 3 are not respecting it, going against it. Okay. So, okay. So that is all I have for today. It was nice to see everybody. I hope you guys have a really good week. I do have meeting schedules, some of you, during this week. If you still need to reach out to me to schedule a time to meet. Okay. And you know where to reach me. Hopefully, you'll have the study guide in the next couple of days. But we've now covered week 4 and week 5. Next week is the end, week 6 for exam 2. So, make sense? Anybody have any questions? Okay, I hope you have a good week. Bye.